Hey everybody, welcome back to the ECG of the day. My name is Reed, and if you enjoy this content, please like and subscribe to the channel. And go ahead, before we start, download this PDF of this document in the description below so that you can follow along and have this ECG in your collections for good practice. So let's go and get started. So first thing we're going to do is we're going to look at the forest, and the trees of the forest are my QRS complexes. And the first thing that I notice is that my QRS complexes appear to be wide. If I just kind of eyeball, it seems to be pretty wide. If you look, they seem to be very regular. What it appears to also be a bit of a slow rate. If I calculate the rate, I'll find this QRS here that lands on a solid line, and I'll count. This time I'm going to count the number of big boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, just over 9, maybe 9 and a third or so. And so 9 and a third big boxes, if you do 300 divided by 9 and a third, then you get the rate. And so the rate here is roughly 32 beats per minute. So I would say we've got a pretty significant bradycardia. And that bradycardia seems to be regular if you kind of just look through the rhythm. So we've got a regular wide complex bradycardia here. So a differential for this is going to include, we could have a complete heart block or a significant AV block. We could have sinus node dysfunction, right? And so there's a few other things that we can think through. And so, I look in front of my QRSs and I do see that I've got some atrial activity. So that is reassuring. But let's actually just dive a little bit more deep into that P wave and look at what the atria is doing. And so I notice that there are P waves here. The P waves are upright in lead 1. They're upright in AVF. So these P waves are coming from the sinus node. Now something that I do notice, however, is that this P wave, there's a P wave here in front of that QRS, but I also see a P wave here that is not associated with a QRS. I don't see any QRSs next to it. So makes me think that maybe this whole AV block idea is a little bit higher on my differential now. All right, but we said it's a wide QRS, so we're also going to evaluate that. And so let's take a look at what the AV node is doing. If we think it's an AV node block, well, the next thing logically to evaluate is our PR interval, or our AV node function. You can see that before every QRS there's a P wave, and that PR interval is normal. It's a normal PR interval, which normal PR intervals are less than 200 milliseconds. And you can see before every before every QRS, that PR interval appears to be the same. And so, that helps me kind of understand, is every P wave, or is every QRS being driven by a P wave? It appears to be the case. And this PR interval stay the same for all of those. And so, what I'm going to conclude here, if we go down to lead 2, we've got a P that conducts to the QRS, and then we have a P that is blocked. P QRS, then we have a P that is blocked. And so every other P wave is being blocked. And so because of that, we know it's at least a second degree AV block, because second degrees, by their definition, means that not all P waves create QRS complexes, but some of them do. And in this case, we're trying to figure out, is it a type 1, is it a type 2? Well, we know that type 1 and type 2s are delineated by, does the PR interval lengthen or not before the drop? Unfortunately, we don't have the opportunity to determine that because we only have 2-to-1 conduction, right? So for every 2 P waves, there's 1 QRS. And so we actually can't delineate whether it's type 1 or type 2. So in this case, we call this a high-grade second degree AV block. And so we've got a high-grade second degree AV block with 2-to-1 conduction. Now we're going to go down and check out our QRS complex. What do we think? Well, our axis, we've got our QRS that is upright in lead 1, but it's down going in AVF. and it's also negative in lead 2, so I know it's going away from lead 2 but towards lead 1, so my axis seems maybe kind of up this way, so I would call this left axis deviation. If you want to learn how to calculate the QRS exactly, I've got actually one good video where it talks about 3 different ways to figure out the axis exactly. But in this case, we know it's left axis deviation because we know it's negative in lead 2, positive in lead 1, so it's got to be at least negative away from this lead, but towards the lateral leads. And so we get left axis deviation. Well, what could cause left axis deviation? Well, conduction disturbances can cause it. And we said we had a wide QRS, right? Our QRS duration is greater than, this QRS duration is greater than 120 milliseconds. So yeah, maybe there is some aberrant conduction. Well, I look for a left bundle branch block. So I look at the lateral leads and I don't see a left bundle branch block. I don't see that R prime in my lateral leads, which are lead 1, AVL, V5, and V6. What I do see, interestingly, is RS, R prime, RS, R prime on V1, and that tells me that this has a right bundle branch block morphology, but that doesn't explain why this is a left axis deviation. You would expect a normal axis or maybe even a rightward axis for right bundle. So we got a right bundle branch block, so that's definitely the case. What you notice here is that we've got this right bundle branch block in the setting of a left axis deviation that also makes you think of, is there a left anterior fascicular block? And so what you can look at is you can look at lead 1 here in lead 3. You can see in lead 1, I'll erase just a little bit so we can take a better look at that QRS. You can see in lead 1 we've got this little Q big R pattern. You can see in lead 3 we've got this little R deep S pattern. And so yeah, that absolutely tells us that there is a left anterior fascicular block as well. So this is a bifascicular block. Okay, so we've got that for our QRS morphology. It makes sense. So we're getting, when the AV node does conduct the signal down from the atria down into the ventricles, we're having it conducted in a bifascicular block pattern. Next thing I can do is look for our pathological Q waves and ST changes. If I look through, I don't really see any deep Q waves. I don't see any ST changes that are elevated or depressed, or T wave inversions that are concerning. But we do have some aberrant conduction, so you're going to see a little bit of ST and T wave kind of flip-flops, but no ischemic changes. And so yeah, let's put this all together. What do we have here? We've got a sinus rhythm that is conducting with a second degree high-grade block with 2-to-1 conduction. We've also got a bifascicular block with a right bundle and left anterior fascicular block pattern. Some people might even call this a trifascicular block. Trifascicular blocks terminology is kind of, the evidence. No one really has a consensus on what we should call it. I don't call it a trifascicular block. I just say it's a bifascicular block with a right bundle branch and a left anterior fascicular block. They say trifascicular because you're also including moments of complete AV node block. Or not complete, but AV block kind of intermittently. So I'm not going to call it that. So yeah, that explains our bradycardia. And this patient is looking like they're going to be a good candidate for a pacemaker. So I hope this helps. If you have any questions, throw it in the comments. If not, we'll see you tomorrow. Have a great day.